So in this video, we're going to talk about the upper quarter screen. And so the upper quarter screen is just going to look from head down to kind of thoracic spine. There's a whole separate thoracic one that you can do. So we're just going to look a little bit at thoracic, but not a ton. And it's a good way to just see kind of what people's movement patterns are, how integrated their movement patterns are into their core, and then help you kind of look for red flags, reasons that they might not need to be in your clinic. All right, so it starts with observation. So I'll have Juliana stand up for me. I'll have her face away from me. And you do want to look head to toe too, because even like pelvis level can throw off someone's shoulder alignment or head neck alignment. And so just things that you'd want to look at would be, are there any creases in the skin? I'd ideally have shirt off. Want to look at shoulder height, want to look for any scapular winging, position of scapula, pelvis height. Even look how they're connected into their feet. Are they pronated? Are they supinated? Do they have compensations throughout? Look at the arms by her side. Does she have like a bigger window one side versus the other? Like on her left side, there's more space between her trunk and her arm versus on the right. And then you can have her turn around and face me. And you'll also look from the front as well. Similar things you're looking at, shoulder position. You can see that her left shoulder is higher than her right shoulder. Looking at position of collarbones. I'm also assessing her breathing. Where is she breathing when she's standing? Pelvis in relation to trunk. So there's a lot you can do just by looking at somebody. And so that's how it starts. And then from here, I'm going to have you have a seat on the table for me. I'm going to stand behind her, and I'm just going to move her hair so I can see. And then it starts with just neck range of motion, okay? First thing I look at is rotation typically, so I'll have you turn your head to the left. Good, looking for quality and quantity. How does fascia move? Turn your head to the right. And same thing, looking for any skin creases, straight ahead. And then look down at the ground for me. How close can she get her chin to her chest? It should touch ideally. And then look up at the ceiling for me, and you can see, does we get movement in upper thoracic spine? Do we just hinge? All those things. Looking more at the quality of the movement. Quantity matters, but you also want to look at overall quality. And then I can look at side bending. Take your right ear to your right shoulder. Good. Left ear to left shoulder. Good. And then now I can add a little bit of some compression and distraction to her neck, see if that causes any pain or discomfort. So add a little compression through her head in neutral, just gently. I also do compression and a little bit of craniovertebral flexion. And then a little bit in extension as well. Not a lot of extension, just very gentle. Good. I can do a little distraction, see if that feels good or bad to her. And then you can also do spurlings in this position. So you can rotate to the right, extend, add a little compression, and then bring her back, rotate, extend, compression. Good. And so that screens out all the range of motion, also tests for part of the radiculopathy cluster. And then move on to shoulder motion. So have you raise your right arm straight up in front for me, just one at a time. When she raises this arm up, her head bends to the right. So I'm just going to notate that for file away for later. Left arm straight up in head, and her head goes to the left a little bit, but not as much as the right. And then do both arms at the same time. Good, and back down. You're also looking at how the shoulder blades track. And then you can look at functional ER. So how far can you reach behind your head with your right arm? Good. And then compare to left arm. Good. And then behind the back for functional IR. Good. And other side. Good. And back down. Now, if you wanted to break out from the screen, you could go further into the shoulder if you thought there was some shoulder pathology. I tend to do that if I think there's a shoulder issue, and then I come back to the screen. So let's just pretend that hers is more of a neck issue, so we're just going to keep going on with our screen. You can add in some thoracic mobility here. Look at her thoracic rotation to the right, to the left. If you wanted to add in some kind of shear movements in the thoracic spine, you could look at how she shears. You could combine quadrant test as well, and just see what her motion quality is there, okay? And so you've got an idea of how the neck is moving, how the trunk is moving, how the shoulders and the scapula are moving. And so now we're going to go more into myotomes, dermatomes, and reflexes. So I'm going to do reflexes first. So we'll do biceps, which is more C5-6, and just see how that reflex is. triceps, C7. You can do brachioradialis. You can do wrist extensors to kind of just check and see, and then do them on the other side as well. You want reflexes to be symmetrical side to side. And ideally it should be a nice like 2+ on the reflex scale. If you see someone that has really big reflexes, it should also match that on the other side. So some people are just a little more tightly wound than others, and that's okay. But if she had a really brisk biceps here and an underactive biceps here, that should just be kind of highlighted that there might be something going on, either upper motor neuron for the hyperreflexia or lower for lower motor neuron. All right. And then you can do the upper motor neuron test as well, just to screen. I did them as a new clinician with everybody just to make sure that I didn't miss anything. And so I would always do a Babinski, a Clonus, and Hoffman's. And so for Babinski, take the reflex hammer around the foot, looking for a big toe to extend. Ankle Clonus, move the foot around, quickly dorsiflex. She has 1 beat of Clonus, kind of hard to see, but let's make sure she has it on the other side. She does, so it's symmetrical. 1 to 3 beats can be considered normal, but again, just file it away. If it was abnormal, keep going. And then Hoffman's is to middle finger. You want to do a noxious stimuli like a flick, and you're looking for flexion of the thumb. Those 3 would be indicative of upper motor neuron lesion. So, you know, it takes a couple seconds to screen them, just screen them out. You never know, right? Okay, and then we can look at sensation. So I'll have you turn arms up, and then I'm going to touch various places on your arms. Let me know if you feel it. Just say yes.
Yes. Yes. Yes. Yes. Yes. Yes. Yes.
You want it to be random, not always timed, not always in the same areas, and hit all of your major dermatome levels. And then myotomes we can do. So biceps would be C5, 6. Start slow. You want to try and do a nice 10-second slow build. And she's good and strong there. And then you would compare everything side to side. The way that I do triceps is I come behind and I have her bend her elbows, have them straighten them just a little bit, and then I do both at the same time, and you can see that right side is a lot weaker than that left, and then go again, hold it again. And you're trying to see, does it get weaker, weaker, weaker each time? It does. And so it's not only that it's weaker from a myotome perspective, but each time it's even more weaker. So she's got a little fatiguing weakness here. If you see that in one level, like C7 is triceps, you should also test another C7 muscle. So we want to do wrist flexors as well. So hold and see, much stronger there. Good. So it could be that it's truly a tricep issue and not a C7 issue. Okay. And then you can do wrist extensors because that's C6. So hold. Good. C8 would be thumbs, like muscles with like muscles. Good. And then T1, finger spread. Again, like muscles, kind of with like muscles. Good. Okay. So that's reflexes, dermatomes, myotomes. After this, I would have her lay down. We're going to look at some nerve tension. You can do slump here if you want to. We'll cover that in the lower quarter one. But now we're going to lay down and we're going to look at upper limb tension testing. So I always look at upper limb tension test 1 because that's part of the cervical radiculopathy cluster. And the way that I do it is starting here at this position. And I use the 0 to 5 scale. So I wind up into the nerve tension test. And then I mark it 0 would be here. If she had some symptoms, this would be a 1, 2, bring them up here, switch to a kind of pistol grip, hold the thumb out, block the shoulder, 3, 4, and then 5. And depending on where they get symptoms, that will tell you what their number is, so that as you treat them, you can retest and you can show that they've improved in their nerve tension mobility. And so that's how I assess just nerve tension. You can go into, median down here. You can do radial and ulnar as well as part of more of a later on piece. But that is essentially how you just do the upper quarter screen. Oh, and then elbow flexion test. I forgot one more, so hop on that for me. And so the last piece is to just look at how well does she integrate her rotator cuffs into her core, okay? And so you start palms up. You want to be in closer to the person here if you can get high enough, or you can come lower. Her and I are the same height, so I'm going to come lower because it's easier for me to have a little more leverage. I'm going to rest my hands here, and I'm just lightly pressing to see, does she engage into her rotator cuff? She has an easier time on her right side. Her left's a little bit harder. And then you slowly pull down to see where she starts to lose the stability piece, and right about there, because she wants to shift forward in her trunk. And so she's right at a 3 for elbow flexion test. We could then, if you wanted to check some impact, you could do, it was worse on this shoulder, I could have her do some resisted axis elongation. So go ahead and do that there. Hold. Here. Up, palm up. And then now we can test one side and see she pulls in much better to her rotator cuff already. Good. I can have her keep holding some more resistance just to get some more stability through her system. Good. And then now both arms up. And then I can retest. And she pulls in much better on her left side compared to the beginning. So that just shows that she needs a little stability through her neck to help stabilize through her shoulder girdle. For her, I bet her triceps are going to be better too. So let's retest triceps. Don't move your neck. Good. Hold. Much stronger on the right. Still a little bit weaker, but way stronger. So that's it for the upper quadrant screen.